Good afternoon, everybody, or good morning, or even good evening, depending on where you are in the world. This afternoon, we have a seminar for you on point of care testing. My name is Professor Paul Collinson. I'm Professor of Cardiovascular Biomarkers at St George's Hospital in London, and I'm going to be chairing the session. Just a little quick introduction here. We all think that point of care testing is a modern innovation, but in fact, this is not the case. This is one of the earliest documented manuals on point of care testing. It was codified in the UK in the Science of Urines, and at this point, techniques included tasting the urine, which is probably soon going to be reintroduced as a cost-saving alternative to this expensive technology. When we think about cardiac point of care testing, really, I'm inspired by that seminal book, The Hitchhiker's Guide to the Galaxy, which said that society goes through three phases, which is survival, inquiry, and then sophistication, or what shall we eat, why do we eat, and where shall we have lunch? And so we've got three presenters today who are going to cover the why do we eat, what shall we eat, why do we eat, and where do we have lunch, in the form of, does cardiac point of care testing work? Is it clinically useful? And how can I make it work for me? So, without more ado, I'm going to introduce our first speaker today, Professor Fred Apple from Minneapolis. Take it away, Fred.
Thank you. Let me start my timer here. Good morning, everyone. I'm speaking today. I hope you all can hear me from Minneapolis. And it's a pleasure to be on this. Thank the IFCC and our chair, Kristen, who is our chair of the IFCC Committee of Clinical Applications of Cardiac Biomarkers. So I guess my title was, how does it work? So I'm taking a little bit different approach this time. Here are some disclosures to look at. I am going to address one specific study I was part of on how essentially does it work. But to start off, some introductory information this is a slide that a generic slide of really cardiac biomarker cutoffs and how we're using them today. And I'm going to be addressing the green box today with a point of care testing. The concept of patients come into our emergency department and our ERs or whatever we designate them, potentially low risk individuals, and how do we establish a threshold cutoff to potentially, with the right clinical picture, which we could never lose sight of, to send patients home. Now, I put this slide up here just to reiterate again and again and again that we're very all accustomed to the fourth universal definition of myocardial infarction, last edition published in 2018, on how we define acute MI with the 99th percentile. But I'm not here to talk about the 99th percentile. I'm here not even to talk about myocardial injury somewhat, but I do think it's important that everyone recognize that the universal definition does do a wonderful job of clearly defining the term myocardial injury as any value greater than the 99th percentile in a pathophysiological state that incurs injury to the heart. So Paul was the lead author of a paper we recently published as part of our committee in the clinical chemistry and laboratory medicine. I'm not going to read through this whole point by point by point, but the important thing is here, which I hope to get across, especially in the clinical aspect, is that good assays, high sensitivity cardiac troponin assays, which we know are defined to be near bedside, different types, we can use them anywhere in the laboratory. Really, the basic definition is defined if we have a non-laboratorian that actually is doing the testing. And the goal of these is to make sure these assays have rapid turnaround time, but also it's important to understand that they have to be validated and derived no different than a central laboratory assay. And what is our ultimate goal? It's analytically robust, it's clinically safe, and I think we'll hear about these things with our other speakers, and it's cost effective. So if we look on our IFCC website, there's tables that manufacturers have published. I'm just going to show you a snapshot here, the claims that manufacturers, but I'm going to focus in on one assay that we just published. I think Paul used the word sophistication in his introduction. I think this is a very sophisticated study that Louise Cullen and I spearheaded on the role and the claim for high sensitivity cardiac troponin I assay in serum and whole blood. On the assay we studied, which was the Siemens Italica VTLI point of care high sensitive cardiac troponin I assay. Now, how do all these assays pair up? We all know that troponin INT will never be standardized because the way the assays are designed for their IP, for the capture and detection antibody, no calibrator or standard will ever be used to be able to calibrate them. And this shows you that if we take a look at the universal sample bank and use plasma, that's the universal sample bank of the AECC, that we see that the 99th percentiles for men and women are going to vary because of lack of standardization and really lack of harmonization. And the assay we studied was the Italica assay. You can see they had 92 sex-specific differences in sex-specific cutoffs for the 90th percentile. But the key was this high sensitivity point of care assay did show over 80% of measurable values above the LOD for both men and women. So the study we published in Circulation is here. They were two governmental clinicaltrials.gov registrations in our countries. I show you here. And the study we studied in the US, we designated as SIEGE, and the Australian study was designated as SAMI. And what's new about these? I will call this was a novel study. In my mind, it was the first consecutive enrolled patients that came in through our programs. And we looked at the high sensitivity point of care assay using whole blood as a derivation, and we use plasma as a validation. As I'll show you with the data, we established a derived and validated threshold, and we'll call it a large geographically distinct cohorts. And you'll see that we defined a threshold that provided potential for early discharge from the emergency department in these very busy, crowded ERs across the world. I just saw a statistic that almost up to 20% of nurses in ERs have kind of declined since COVID for many reasons. So having a rapid, and this assay is less than 8 minutes, test, and I know there are others on the marketplace that are being studied, this will provide the potential for a throughput that we haven't seen before, besides the goal of having 1 hour turnaround time from the central laboratory. All right. So our study goal primarily was to aim to both derive and validate an optimal threshold down by the LOD, and using a single sample at presentation to help identify patients not only for early rule out, but also at a low risk, less than 1% of an index MI for potential early discharge. And here I mentioned our cohorts before. You can see our enrollment. This was back in 2020 through 2021 for both institutions. And we have your classical exclusions. There's no reason to use and to study the STEMI patients, the ST segment elevation MI, because those are pretty much very aggressive to get to the cath lab early, right? Both studies were IRB approved appropriately. So the assays we use, and this was also another strength of this, I love that word, Paul, sophisticated study. Our derivation cohort, we paralleled the use of whole blood that came in as a clinically requested troponin was ordered for patient care. And over, I said 24/7, we measured the whole blood at the same time as our central lab assay was the Architect I-1000, which was a plasma, but we used whole blood on the Italica VTLI assay. Louise's validation cohort was again, a consecutive enrolled patients over time, but she took the plasma and froze it. And she essentially validated based on her clinical assays the Beckman-Coulter high sensitive troponin I. So here what we have is two different central lab high sensitivity assays deriving and validated our diagnostics and our outcomes. So both sites use either emergency medicine or cardiologist to adjudicate MI, no MI, type 1 and type 2 based on the fourth universal definition. Our threshold, our goal was very aggressive, sophisticated, I'll say that again, to base our selection criteria for the optimized cutoff that had both a 99.5% negative predictive value as well as a 99% sensitivity for index MI. And then again, we used the concept of MACE at less than 1% 30 days risk, including unplanned revascularization as our 30-day outcome measure. So here are the start of the results. We had 2,572 patients in our study. You can see there were 1,086 in the US cohort, SIEGE, and there were 1,486 in the Australian cutoff. And I'm just going to look at my derivation group. So in our group, we had 8.1% total MIs. It was in our hospital, we're an intercity hospital. We see a lot of sick patients that don't come in for routine care. And our type 2 MIs were much greater than our type 1 MIs. So one of the limitations was the small number of type 1 MIs in our study. Comparatively, we saw a slightly less number of total MIs in the Australian group, and that you could see here there was more type 1 MIs, 3.8% versus 1.6 for type 2s, all right? The non-AMI group, we had classification of myocardial injury. We were seeing anywhere from 19% in our group to 6% in the Australian group, right? And the rest you could read there. But one other caveat we have to put out here is, and we've learned, and jumping ahead, typically this rule-out protocol and our results will not typically work in patients presenting less than 2 hours after the onset of symptoms. So this is really a data set that's going to be very strong if you're 2 hours or greater from the symptom onset. And our early presenters in our group, we had 19%, and in the Australian group, there's about 24%. So here's the data, the first of all. This is the data using the whole blood point of care high sensitive troponin I assay for the optimal, defining and deriving an optimal cutoff. Now I call this the Nick Mills graph, where Nick first championed that I saw showing a graph of the percent of patients, but looking at the negative predictive value and the sensitivity on a graph, and then looked at a cumulative index of patients over time. So if we look at this closely, and I'll go through a table, our ideal 99.5% negative predictive value and 99% sensitivity was at a less than 4 nanograms per liter value for the VTLI assay. And when we focus in on the data, there's a lot of data on the slide, we felt strongly that we were going to show data for all the potential cutoffs for negative predictive value and sensitivity. So while some people will focus just on the 99.5% negative predictive value, which we found, and I show you our 95% confidence intervals, our sensitivity was 98.9%, and we only saw an 18% rate of potential discharge at that rate. And you can see here we had one event that was missed in this population. Now, if we look at the Australian cohort and validating our cutoff for the less than, my apologies, should move that arrow to less than 4 cutoff, and this was based on plasma, and we focus in here on the less than 4. Louise's SAMI cutoff was also very good, 99.8% negative predictive value, and just about little less than 99% for the sensitivity. But in her cumulative number of potential routes was about 42%, much different than our US population. And I'll explain why that was in a second. Interestingly, when we looked at the patients in this group at the diagnostic accuracy, you can see both SIEGE and SAMI had one false negative rate. And if we take a look carefully at the index MIs, we had no false negatives. And when we looked at the 30-day MACE, when you look at my circle, our group, we missed 1 event. In Louise's group, we missed 5 events. And if you go over to the negative predictive value, you can see it's very powerful, greater than 99.5% in all the populations. And even when we look at the 30-day adverse events rate, it was 99.5% for the SIEGE and 99.2% for the negative predictive value. Who were these patients we missed? If you look, I'm not going to read through this, but if you look at this carefully, what we observe is they were mostly type 2 MIs or unplanned revascularizations. There were only 2 patients that had a STEMI type 1 MI, excuse me, not a STEMI, an NSTEMI type 1 MI, and one was an early presenter, and one that was from the SAMI group, and one was a 58-year-old that presented slightly after 2 hours. So not atypical that these would be the type of patients that potentially would be missed. So let's talk about what this report showed here. It's really the first safety and accuracy report that showed in a single sample using a whole blood test for rapid exclusion of MI in the emergency department. There are other studies using frozen convenient samples for using plasma for different claimed high sensitivity assays in the market share, but never in a whole blood setting, right? The time savings based on a less than 8-minute turnaround time to be done in the emergency department offers a very powerful ability for triage and making clinical decisions rapidly while the patients are still there in the ER over the first couple hours. As I talked about, there was a substantial difference between our 2 sites. And it turns out what we discovered, and we didn't really think about this, at my site at Hennepin, we've been using an algorithm to send patients home on a single sample for a couple of years. So all the patients that in Louise's SAMI group that required a 0-2 hours to enter in the study, for both our studies, the SAMI group, always part of their clinical care, required a 0-2 hour sample before they made a clinical decision. In the SIEGE group at Hennepin, we were sending patients home just based on a single sample. And when I took a look, we just got done reviewing these. We reviewed almost up to 1,950 patients that went home in our large data set that we enrolled patients for our studies. If I looked at those and we just got done with chart reviews, we would have ended up, if we actually had a 2-hour sample on those single sample rule outs, we would have had about a 60% potential discharge rate based on that. So they've been a very powerful tool to rule out. So a learning thing in design of studies, something we typically miss, we actually missed in the first way we designed these studies, that the sites were designed a little differently in how patients were enrolled and even cared for. One last piece of data I will throw out here is, as we think about point of care and we think about the use of high sensitive troponin, and is that we have to think away from these just dichotomous numbers. I showed a study here that it was showing carefully if we used a single threshold of less than 4 nanograms per liter, we can make some very powerful tools. Now, this is not from the SIEGE SAMI group. This is from an earlier study we did called Utopia. This was predicated on about 1,600 patients that came through our emergency department based on the Abbott Architect assay. None of these patients during the course of their stay ever saw a troponin above the 99th percentile. We separate them by men and women. And what we see here, it's not just a straightforward continuum of adverse events. We're looking at the percentage of major adverse events at 180 days in this group. So even though it's a reference range, probably not good to call it normal, because these are patients that came in with some reason and the clinicians ordered troponin because they had some suspicion of the heart. So I caution against the use of word of normal. We used to call them normal ranges. They're reference ranges. We use the upper reference limit as our 99th percentile. And you can see here there's great risk, even within the reference interval. I have an arrow there for myself. That was my troponin a year and a half ago. So I feel pretty good that my risk is very low. But you can see here within the 99th percentile, which is different for men than women, there's a 2 to 3.5-fold greater risk as the troponin never bumps above the 99th percentile, but yet is elevated. So keep that in mind. And in summary here, point of care, high sensitive whole blood assays can work and do work, as in this case. This assay, the VTLI assay, is not FDA cleared. I think there's studies undergoing in the US. It is CE marked for use outside the rest of the world. I think it's a very good assay. It does provide the ability to have a strategy to set up an algorithm for early rule out. This is a single sample. Louise and I are working on a 0-2 hour delta rule out in addition to those patients who are above the 4 nanogram per liter, but less than the 99th percentile. And I feel our findings here show great promise for improving patient care, and for especially if you're an inner city population, or you're in a medical center that's very busy, or you're in a rural setting out in, let's say, 200 miles from a city. This type of a point of care whole blood assay will give laboratories, whether it's point of care in the peripheral, or in a rural clinic, or in a medical center that does 24/7 with very few employees, it does provide numbers that are good to make clinical decisions. In addition, I feel, although we don't have the numbers, it'll be at a financial cost savings, especially getting patients through the emergency department. I thank you very much. And I don't know if we're taking questions all at once at the end. I think we are. And appreciate the opportunity to speak, and I look forward to the Q&A later. Paul?
Hi. Hello there. Fred, I've got a couple of, actually, I'm going to give you a couple of quick questions now because they are pertinent to your talk. One question is why you didn't use whole blood for the second part of the study, the SAME study. And the second is, did you actually do the measurements in the ED, or was it a lab-based study?
So the answer to the first question is because of time and getting materials, that Louise had a wonderful data set already frozen on plasma. So we did split it up, I guess a little bit convenient to be able to get it done in a reasonable length of time. All right. So in the long run, actually, we validated both the whole blood and plasma, which I kind of liked. But that's the answer. Ideally, we would have validated, and it should be done with whole blood. And so I encourage people to validate the same concept with whole blood in a different setting. The second was to do this, to do it 24/7, 7 days a week. We did put the point of care instruments into our central laboratory. They weren't run by nursing, and they ran them alongside the architect as they ran the samples. Now, we trained them no differently than we trained our nurses to do point of care, and at least for our quality control, where we were seeing CVs at right around the 4 nanogram per liter cutoff, around 20%. Again, Paul, that would be a limitation, and it would be ideal to do this in the setting where, let's say, in the ER, where a true point of care analyst would be running these. I hope I addressed your questions.
Yep, that's very good. Thank you very much. Okay, well, now I'd like to invite Louise to join us and present her talk on what do we need to know.
Thank you very much, Paul. And thanks also, Fred, for setting the scenes. I'm just going to share my screen for now. And I've been asked to talk about what sort of real life data do we need? When we talk about highly sensitive point of care troponin assays, what do we need to put them into practice? Here are my disclosures. I am on writing committees. Of course, I'm thrilled to be a member of the IFCC Committee of Clinical Application of Cardiac Biomarkers, and I work with the major biomarker companies. But most importantly for my disclosures is that I'm an emergency physician, and I'm a clinician first and foremost, but I do love doing the clinical research. I did start this presentation with a question about thinking about what does it take for us to get a point of care troponin assay, a highly sensitive point of care troponin assay, into use in your clinical ED. And I guess I've put 4 different questions out here. I'm going to get to the answer at the end. But the first thing is, do you need independent evaluation determining the 99th percentile of the assay that has been performed locally? The second part, do you need randomized controlled trials that assess the clinical safety of new assays in clinical use? Third, large clinical trials determining optimum strategies for use in the ED. Or fourth, the health economic evaluation about the potential impact has been published. So as we take a step back at this, we've got to look at the why and the what. What are we trying to achieve and why? And it's fair to say that it is increasingly tough to be a clinician in the ED space. In Europe, ED visit rates have been rising at an annual growth rate of up to 8.5% between 2001 and 2011, according to the OECD report. And if you take a US approach, there's been a recent emergency medicine task force that projected an increase of ED visits to an estimated 159 million visits a year by the time 2030, which with the highest rate in our patients over the age of 75. And these sorts of figures are quite alarming. Now, I am a realist. I know that this isn't how our emergency departments will be. But when we think about the proportion of patients that are contributing to the busyness or the workload of the EDs, chest pain is the leading or the second most common reason why patients present to the emergency department. Luckily, the majority of patients do not have a myocardial infarction or any other serious cause for their symptoms. And so many places around the world have been introducing strategies for management based for patients with suspected acute coronary syndrome based upon highly sensitive troponin assays that are included, for example, in the ESC guidelines or the high stakes pathway. And these are aimed at identifying large proportions of patients, often up to about half of them, to be discharged with a single troponin result. These, though, have been very much based upon the lab-based troponin assays, where ideally we have turnaround times for results to be available to us within 60 minutes, but realistically it's often a lot longer than that. That 60-minute time period, though, means the reality is that no matter how quickly you see patients, there's wait times for those results, and second or third need to go back and see patients before you can make final decisions about what is going to happen with that patient. And recently, as Fred has said, we've been looking more and more at point-of-care highly sensitive troponin assays. And the question then comes to us as clinicians about, can a point-of-care assay with a highly sensitive troponin result that provides us with information in less than 20 minutes, ideally less than 10 minutes, improve decision-making time and time for disposition? Because what I need to do is try and decongest my department. And I know that probably from those of you in a lab, when you look at 20 minutes versus an hour, you're thinking that doesn't really mean a lot. But when you look at the numbers and things, I think it's important to take a step back and re-look at all of these strategies that we can potentially implement to improve efficiency. If you're running an ED, for example, with 100,000 patients a year, and I know that's a fairly large one, but it means you're seeing probably about 8,000 patients a year with suspected acute coronary syndrome. If you can save 40 minutes per patient, this may mean ultimately creating capacity of the order of over 200 days per year. And I'd argue we are not getting any other initiatives at the moment that are giving us back time and space to care for the ever-increasing numbers of people coming through. And look, when I say that, I do acutely acknowledge that probably only half of these can go home, but for the other half, if we can make early decisions about whether or not they need to be admitted, it also contributes to the efficiency. So let's get back to the question, and that is about what sorts of studies do we need to be able to implement troponin assays? And I think about these in three different sections, and that is assay evaluation, diagnostic accuracy, and also clinical implementation. When we look at highly sensitive troponin assay, I want to acknowledge that there are very different perspectives and needs of the different groups. Our laboratorians, or pathologists as we call them here in Australia, our clinicians, whether they be emergency physicians, cardiologists, general physicians, but also our health executives require different things potentially out of a point of care assay. And so the question comes, can one trial or one trial design actually be everything for everybody? I'm going to focus again, as I said, very much as a clinical researcher. So with my aim always being, how can I improve patient care? And does this lead to improved efficiency of care that ultimately will ensure we've got the ability to care for patients or provide high quality healthcare in the future? Before any clinician should look at any assay, there's a few fundamental things that need to be evaluated. And this is very much the work of our laboratorians and our pathologists, and that is, does the assay work? Please, we are reliant on high quality studies that show us the analytical characteristics of an assay, including things like the precision, interferences, and the important metrics, things like the 90th percentile, LOD, LOQ, and the values corresponding to 10% CV. That's all the first step. And I'm really not going to give this any more time because for the purpose of this talk, we're going to assume that this aspect has been done and done well. So let's focus on the clinical question, which is this assay safe? And really what we're asking then is, can you provide us with diagnostic accuracy studies so that we know that this assay can safely identify patients with the clinical condition, and that is acute myocardial infarction accurately. Now, Fred has talked a little bit about this, so I'm just going to give you a different perspective. You'd think that this would be really easy. You know, we've just got 2 different assays, same condition, this should be great. But it's actually a little bit more complex than that. So by definition, the 4th universal definition of myocardial infarction, which is one of the key components to the diagnosis of AMI, is an elevated troponin value. There is no independent gold standard that we can compare against. So you cannot, of course, be diagnosed with or identified as having myocardial injury unless you've got an elevated troponin value. And the result from the troponin value that is in clinical use then will go and drive the other activity that happens. So whether or not you're admitted or have further investigations that include angiography often very much depends purely on the elevated troponin level. I do agree that sometimes it's ECG and sometimes it's symptomatology, but the troponin is a big driving thing. So when you think about the clinical assay in use, if for any particular patient that's not elevated, then often those patients are discharged. And as we know, and Fred has just spoken about, the troponin assays are not harmonised, they are not standardised. They've each got differences in their analytical performance, and there's manufacturer-specific antibody and antigen epitopes to take into consideration. So essentially what that means is the comparator assay can never be better than the clinical assay. And that's an important thing to think about. So we're really sort of saying that it's non-inferior. It's as good as, but not significantly worse. And there's other things also. If you're using a clinical assay and you're not using sex-specific cut points, you're talking about a new assay and you are evaluating the sex-specific cut points, that also can result in differences in the results because they were not used in clinical care. So again, no new assay can ever be better than the old one. Now let's get back to sort of something that's a little dry. I'll see if I can make it a bit more interesting, but that's levels of evidence. And I think probably many people are familiar with this traditional pyramid of evidence where we have systematic reviews of randomized controlled trials being level 1 and randomized controlled trials being level 2, following on to cohort studies and case control studies. Here in Australia, and it's not different to any of the other international guidelines, the National Health and Medical Research Council provide us guidelines about differences, different studies and recommendations that are required. And they note that levels of evidence actually need to vary according to the type of research question, whether it be an intervention, a diagnostic accuracy, prognosis, etiology, or screening. We're not going to talk about those last 3. But when we talk about this traditional pyramid, we are talking about an intervention. And I'd argue that just in the development and evaluation of assays, we're not quite there yet at this point in time. So hang on, we will get there though. When we look at diagnostic accuracy, level 2 evidence is like the one that Fred has just described. It's a study of test accuracy with the independent blind comparison with a valid reference standard, i.e. the clinical assay, among consecutive patients with, in this case, a acute myocardial infarction. And so Fred has gone over this paper in great detail, so I'm really not going to need to go over all of the nuances, but it's essentially what we did. We looked to see whether the Siemens Italica VTLI point of care assay, whether we could identify a threshold that gave us a very high NPV, greater than or equal to 99.5%, and a sensitivity greater than 99% for index NI. And that's, you know, really trying to identify the how we could use this assay in clinical care. And Fred has highlighted the differences and similarities between our cohorts, which were very good. And I guess one of the key things that I'm very pleased about is because of the sizes of the studies, we've actually got very tight confidence intervals around our point estimates of sensitivity and NPV. And again, he's shown you these incredibly valuable, rich figures that we've given. And I do think going forwards with further studies, we need to be, as researchers who are publishing in this area, we need to present all of the data. which then would enable individual people to discern what might be appropriate for implementation in their setting. So presenting all of the data, like Nick Bill started doing, I think all of us should be beginning to think to replicate that way. Now, there is another study that Jasper Boddinghaus and Christian Mueller have published on a point-of-care high-sensitivity assay, and that was looking at the triage true point-of-care. And within this study, they used stored plasma samples, but looked at both a single cut point for ruling out and also then values at 0 and 1 hours for ruling in or ruling out, or placing patients into the typical observation zone as recommended by the EC guidelines. A couple of the questions came up that are going to I was going to discuss, because I think there's some other important things to think about. And when you look at these papers, you've got to think, well, are we just changing the assay itself? And that's rarely it. So a key bit for me is that who's going to be using this? And I'd say that the device must be challenged in the environment where it's going to be used and operated. And the typical end users within the ED, we're fairly, shall I say, robust evaluators. Any point of care device needs to be able to withstand the chaos in the ED and be able to give us consistency and reliability and accuracy. So one of the things when you read all of the different papers in here is look at who's using it. Is it the lab people or the end users? Again, what is the sample type? And we highlighted that there's 2 different sample types in ours, but for others, we've got to look and say, well, do matrix studies demonstrate similar performance between plasma and whole blood, for example? Do they need to be repeated in fresh whole blood collections for point of care studies? And this is one of the things that we need to do to really progress this area. And the last aspect, which is what we're going to move on to further, is about the true value of the clinical use of the assay itself. If we're going to introduce the assay, are we simply swapping out one using the same sort of process and for example, the same sorts of timing, or are there other changes? And here's where we're going to move on to the final kind of study. And this is our clinical implementation. This here is the true traditional hierarchy where we're looking towards randomized controlled trials. And randomized controlled trials in this space is difficult. I'm just going to point out this paper, which was by Derek Chu, led in Australia, which looked at randomizing. It was an inpatient, patient-level randomized comparison of a 0 and 1 hour high-sensitivity troponin T protocol versus a 0 and 3 hour strategy. And within this, again, balanced populations, but the metrics that he was able to report include things like proportions of patients being discharged for the ED and ED length of stay. There's also a safety analysis evaluating the MACE rate or death rate or MI rate in those patients who were discharged, again, with very high confidence in the safety of this with very high negative predictive values. And I want you to look out for the iCare FASTER trial, which has been registered for the ANZ Clinical Trials Registry and is being led by Martin Van in New Zealand, which is going to be putting a point-of-care troponin into EDs across New Zealand in a randomised fashion to identify the impact that it's going to have on patients with potential ACS. The randomised strategy here is going to be a randomised step-wedge study design whereby the hospitals or the EDs will be randomised en bloc across the country to implement them on different times to evaluate some of these metrics. But you can't get to this space unless we've got confidence in the diagnostic accuracy. So this is the sequence of events. And just as a tiny little segue before I end, one of the things that I look at when we see a number of publications in this area is you often see people publishing fabulous point estimates of things like negative predictive value being 99.5%. And look, this is great. And what this really means is that we'll only miss one patient with an MI in 200 patients. But I'd argue, please also look at things like the confidence intervals, the range of around them, and some of them, concerningly, when the studies are small, get quite low. And it's because that our event rate, the true AMI rate in the ED population, is low. And if we have got a small sample size, we are going to miss identifying those patients. So we need very large studies. It does mean these studies are hard to do, but we need them to ensure accuracy. So in terms of what do we do when we've got a new highly sensitive troponin assay, point of care, what do we need? We need firstly the analytical studies to be done and done well. We need our clinical diagnostic accuracy studies in large consecutive cohort trials. And then we need our implementation studies, ideally in randomized controlled trials, whether that be patient-level randomization or step-wedge randomization as well. So look, in terms of the question I proposed before, I strongly believe that we need large clinical trials that determine the optimum strategies, but the other ones are not needed before we're able to implement a high-sensitive point-of-care assay within your EDs. And look, thank you very much for your time. I'm going to look forward to any of the questions.
Okay, well, thank you very much indeed for that, Louise. The questions that have been coming in so far, you've been such a model of clarity. No one's actually asked a direct question of you, but there are some general questions which I'll put to the panel later. Okay, well, I'm going to ask now for the where should we have lunch phase, and get Kristen from Bergen to give us her talk on what you need to do to make this work. Over to you, Kristen.
Hello, can you hear me?
Yep, we can hear you.
Okay, I'll then try to share my slides.
And we can see you.
Thank you, that's excellent. So thank you for the introduction. I'm going to talk about implementation of troponin assays, point-of-care assays in the institution. And the question is, are we ready? And I think the short answer here is no. But I will take you a little bit more into the details. And my talk will focus on when, why, where, and how to use point-of-care troponin testing. I think the when has been covered quite well already, but just reminding you that for every troponin assay, point of care or central platform, we need to know the basics. So it's the assay characteristics, we need to know if it's high sensitivity, and we need to know the clinical use and interpretation. And all this information can actually be found on the IFCC webpage from the Committee on Clinical Application of Cardiac Biomarkers. You just go to the web page and look at this biomarker reference tables. This information is from the manufacturers. The good thing about that is that if we use, for instance, the 99th percentile from the manufacturer, it will be the same for everybody. If we validate them locally, we will have slightly different percentiles. So that's different approaches, and there are cons and pros with both way of doing it. But even so, the information is here, and please take a look at it. If you want to do accelerated diagnostic protocols, for instance, in your emergency department, to have the patients fast through, you also need to validate the cutoff or have cutoffs for that, which has already been discussed. This is not on the web page, so you have to go to the literature or to guidelines to find these cutoffs. So why? When you are considering if you want to use a point-of-care assay, you have to actually decide what benefit this will be for your patient and for the care you provide. There are two major things that should be considered. First is the turnaround time. Will it actually help your patient if you can reduce the turnaround time? And the second thing is the increased availability that point-of-care assays may provide, if that will be a benefit for your patient. The pros for troponin assays are quite obvious. Of course, there is a reduction in the turnaround time. The instruments are small, portable. You can take them everywhere into the patient room. You can even take them in your car and drive home to the patient if you want. There's no need for dedicated laboratory staff. You don't need to centrifugate your samples. And capillary sampling will also often be possible, so which is a large benefit. If you don't have laboratory staff, you don't need to take venous samples. There are cons, though, which should be considered. Point-of-care testing is expensive. It's much more expensive than central platforms. The throughput is low, So if you are in a very busy emergency department, you will probably need several analyzers. And there is also probably, I have not seen data on this, but I'm pretty sure that the waste goes up if you do point of care assay. There are also something in the middle here which I've called neutral, which is not actually neutral. It's just that it's both benefits and drawbacks here. The first one is the calibration is integrated, so, which is very fine and a large advance when you don't have laboratory staff available. However, if you have several analyzers and there is a shift between them, there is actually not very much you can do when the calibration is integrated. So then you have to kind of live with that shift. Compared to the central analyzers where you can do calibration and try to align them much better. The online reporting is not always obligate for point of care assays. We very much recommend online reporting, of course, because the error rate goes down. And I think it should be the rule also for point of care assays, but sometimes it's not possible or you need to implement the assay very fast, then it can be done without online reporting, and that could be an advantage. Also, point of care assay will bring about a much larger or closer collaboration between laboratory and clinical staff, I think. And that is a large advantage, which we usually really wish for. However, there is also a risk, because if you fail, for instance, in your collaboration and in your information strategy, there is a larger risk for mistakes and misinterpretations when you have these point of care assays, troponin point of care assays in your institution. So there is a benefit, but also a risk. So why should we do it? We have to document the benefits before we start, I think. And Louis and Fred has already talked about the safety issue, which is, of course, the most important thing. And the current recommendations are 99.5 negative predictive value. And there is a discussion if it should be 97 or 99% sensitivity for MI and death within 30 days. I think we should also consider long-term data for safety, because we don't really know if this very large reduction in contact between healthcare staff and patients, for instance, if that's beneficial. For instance, usually or before, patients were maybe admitted for 24 hours, and now they are only 2-3 hours in the ED. We would think if they don't have myocardial infarction or any serious disease, that doesn't matter. But we are not quite sure, and there are some data from, for instance, from the rapid TNT trial, which Louis referred to, which indicate that it could be beneficial for patients to have a longer contact with the healthcare system, because we don't know why, but maybe it's possible to detect other healthcare conditions, or maybe they get more treatment or prevention if they are longer in contact with the healthcare system. We don't know that. So, but it is a safety issue we should consider. Also, we need to know and we need to document that this is actually efficient, and that there is a good cost efficiency. And the way to do this is first to look at your logistics. Are they really dependent on the turnaround time of the troponin assay? Because it doesn't help your patients that your turnaround times come down from 90 minutes to 9 minutes, if that is not an issue. If they still have to wait 3 hours for the nurse and 4 hours for the doctor and an x-ray and so, it wouldn't help to have a reduction in the turnaround time for troponin. So this, you just have to go through the patient flow, look at the bottlenecks and see where are they, and is it likely that reduction in turnaround time for troponin will help you. And if it's not likely, well, maybe you should focus on something else first. Also, I think it would be a very good thing to test this during the implementation of the assay to see that it really helps. If you're outside the hospital and use the assay, you should also measure the effect, and that could be, is there any reduction in patients who present to the emergency department? Are there reduction in ambulance transports for chest pain patients? Things like that should be measured. And another thing that is important is actually to ask the patients, are they satisfied with these very rapid protocols? Some patients will be, some patients will not be. And we should do that systematically and actually ask them, are they satisfied? So, where should we use it? We have already talked a lot about emergency departments. I will not say very much about that. We know that prolonged stay in emergency department will increase mortality in general, and we all agree that that should be reduced, and that point of care assay is one very good option to do that. But there are other possibilities as well. Very recently, the European Society of Cardiology recommended that we measure troponin before and after non-cardiac surgery to detect perioperative myocardial injury. This should be done in patients with known cardiovascular disease or high risk of cardiovascular disease. And we should then calculate the delta value between the measurements to diagnose this PIM or perioperative myocardial injury. This has not been quite successfully implemented yet. I think it's because the clinical community has not totally agreed how to use this diagnosis. What treatment should it, and follow-up should it lead to? But I think there will come more data, and this will be more and more implemented in the coming years. And then there will be institutions, surgery hospitals, so and so, which has less access to central troponin measurements or have very slow, very delayed results. And for those institutions, point of care could be a possibility. Similarly, there are also recommendations that patients treated for cancer should be screened or monitored before and during the treatment. That's depending on their baseline cardiovascular risk and the cardiotoxicity of the drug. And also in this kind of institution, it could be a possibility to use point of care if there is limited access to central laboratory analysis. Also, which has been discussed here in Norway at least, is that we have many small laboratories, small hospitals who treat patients with acute chest pain or myocardial infarction. And in these hospitals, it could actually be, you have your central platform with only, you really don't need more than one analyzer because you have so few patients. You need two, you always buy two because you need backup. It could be a possibility to use a point of care assay as backup. If you have, but then you need to have some kind of emergency plan to use when your central platform is down, so that you know how to implement the assay results. Also, if in some larger laboratories we would like to have a comparator method, a second troponin assay to use, for instance, when we are suspicious of interference in the central platform and so on, then point of care assays could be a very good option. Another place of utility is, of course, outside hospital, and this is actually depending on your country. If you have a rural country like here in Scandinavia, many patients are with a low intermediate risk. They do not go directly to the hospital because the hospital is very far away. So they go to urgent treatment centers first, where they are investigated. And these centers, they could very much benefit for a point of care assay. I think it would increase both the sensitivity and probably also the specificity of their diagnostic work. Nurseries, other institutions could use point-of-care assays, so they don't need to transport patients to hospital to have a troponin assay, a troponin measurement. Also, of course, in ambulances, this could be very useful. This is a picture from Norway showing you where people actually live. And of course, if you have a patient with chest pain here, there are two ways to deal with that. You could either have a boat, an ambulance boat, or a helicopter coming down here on the red line to pick up the patient. But if those are unavailable, you have to have the ambulance coming from here, driving all the way down, pick up the patient, back again, and with a ferry to the hospital. And I think you agree with me that in these kind of situations, it could be useful to have some troponin measurements to know how to prioritize that patient. How do we do it? I've already said this, but you have to work very, very, very close with the clinicians and the laboratories. I would suggest to set down some implementation committee who first should go through and collect all the relevant data and information, and then set up a plan both for related to the analytical parts of the assay and the clinical part. And there should be very clear and easily available guidance for the clinical personnel who will take the samples, analyze them and interpret the results, but also for the lab personnel who will be behind to maintain and quality assure the instruments. You will very fast find yourself in this position, one hospital, two troponin assays, and that's not a very easy place to be. First of all, if you measure a chest pain cohort with troponin T and troponin I, you will see that there will be 4 or 5 times more results above the 99th percentile for troponin T compared to I. And you have to deal with this if you have both these assays in your hospital, because then one patient will be negative by troponin I, positive by troponin T, and you have to have a plan how to deal with that. Also, if you have 2 different troponin I assays, one in the emergency department, one in the central lab, for instance, well, the concordance between the 2 assays will not be very good. Current data suggests maybe a correlation coefficient around 0.8 or below. And these 2 assays will have different 99th percentiles cutoffs, and you cannot use the result interchangeable. So you have to have a flagging system so that your clinicians will know from what assay the results are, and don't mix up and calculate delta values from 2 different assays, for instance. There are several ways to solve this. One could be to use only the one troponin assay if you have started to use one troponin assay, you will continue to use that assay through the whole hospital stay. Or if you want to switch, for instance, from the point of care assay you have in the emergency department to the central platform, which you use for the admitted patients, then you should probably reanalyze the initial and admission samples using your central laboratory assay, so that you have a complete series of troponin results from one assay. If not, it can be very difficult for the clinicians to interpret this. And you have to have a plan for how to handle divergent results. If one assay is positive, the other is negative, you have to know how to deal with that. If you're outside the hospital, it's easier because you only have one assay. On the other hand, sometimes if you are the competence of the staff will of course be lower outside of hospital than inside. So very clear guidance should be given, and also you need probably to set up some kind of telephone conference or possibilities for the paramedics to consult the hospital regarding how to deal with a result and what should be done for the different patients. When you come then back in your lab and hospital and want to actually implement the system, you have to be aware of the technical and practical issues that must be undertaken. And I think this should not be underrated. If you want online reporting, and my clear advice is that you should want that for 99% of cases, well, to get the new instrument integrated into your electronic system might take several months, maybe up to 1 year, depending on the local regulations. You need to qualify the clinical staff, and that can be a challenge if you have in 24/7 shifts, because maybe some nurses, they only work during night shifts, so it's not easy to get hold on them. And since somebody is always working, you have to have several setups for teaching. Also, there can be some cultural issues because somebody is going to have a new working task on their list, and this has to be accepted, because sampling and analyzing will be moved from the lab onto the clinical staff. There's a lot of practical issues, which is very simple but still needs to be thought about, like power supply, online connection, storing facilities, and so on. The devil is always in the details. So you need some also the usual things for analytical quality, internal quality assessment. How often should we do it? Well, the manufacturers maybe say once a month. The quality assurance organizations here in Scandinavia who take care of point of care, they typically say once a week. And my advice would be start often and go down if you see that you don't need to do it so often. And if you have an instrument outside hospital, there has to be a plan who's going to take care of the quality and maintenance of that instrument. If you have several instruments in your ED, for instance, you should probably have a system for running correlation between the instruments, so you know how large delta values are between them. And maybe you should not use them interchangeable if there are large delta values, especially not in these very small rule-out, rule-in algorithms with very small deltas. Also, you need external quality assessment inside and outside the hospital. So, conclusion, I think point-of-care troponin instruments have a very large potential to improve patient care, primarily by improving the logistics and availability of troponin measurements. And we will be able to provide high-quality results also outside hospital, which is a large benefit, at least when patients are in countries which are very rural. We need a large amount of scientific data, primarily about the safety, of course, but also related to the whole setup, cost efficiency, practicality, and patient's view. And we need long-term data also. It's a complex process to implement point of care. It involves medical, technical, logistics, and practical issues. And when you do that, remember to include all the stakeholders: emergency physicians, cardiologists, nurses, technicians, and the labs. And all of these have an important part in the planning and conduct during the implementation process. Thank you.
Thank you very much, Kristen. And now I'm going to invite everybody to come back up, and I shall field the questions which have been flooding in. I've dealt with some of them. But, I'm just going to kick off with the first one, which is slightly interesting and slightly contentious. I've been asked, wouldn't it be beneficial to have copeptin on the point of care testing device as well as troponin? I'm going to answer that fairly swiftly, in that basically my understanding is that copeptin offers no diagnostic improvement in the presence of a high sensitive troponin assay. And I'll ask if anybody else wants to contradict me on that one.
No.
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 That's good. I've got a second question here, which is about hemolysis, saying as there's a high incidence of hemolysis, would it be a good wheeze if we had a hemolysis detection device that could be used when the bloods were taken for point of care testing? Anyone got any comments on that one? Fred?
So I think like everything we've all talked about, you have to know your assay and you have to know the role of, especially in a whole blood point of care device, hemolysis and even hematocrit. So those analytical features have already been worked out by manufacturer and hopefully validated by someone. But I think your concept, Paul, is a wonderful one. If manufacturers can build in, I'll use the Roche assay. We use Roche for some of our testing in our hospital, like the H index that they provide. If that type of index was available on a point of care, it would be fantastic. Similar type of concept. Especially if hemolysis affects the troponin result. Yeah. If it doesn't, then it's not a problem. But if it does, having that ability without having to spin down the whole blood after a result is given with an assay that does have interferent, having that H index type of concept is a really wonderful idea.
Any other comments from anybody?
No, just in agreement with Fred.
Right. Okay, I've got there's a bit of a common theme in a number of the questions asking about well, first of all, shouldn't there be more effort made to standardize troponin? Because what happens when you have a point of care assay and a central lab assay running in the same place? And I think my comment to that is I'm a bit like Fred. I don't think it's ever going to happen.
Go, Kristen, you go first.
I agree with you, but I also disagree. I think some of the manufacturers who have central platforms, if they can make a point of care assay with the same antibodies and calibrate those towards each other, it could be a possibility to have a point of care and central laboratory assay, which are quite similar. That's the only option I can see at the moment.
So along those lines, I'll make 2 or 3 comments. One, we're never sure if, let's say, the point of care division talks to the central lab division when they're designing assays. So Kristen's point is well taken as far as how antibodies are designed. But secondly, as Paul, as we all know, there's been work for 20, 30 years to try to harmonize, because everyone knows standardization would never happen, even harmonization. And I know there's an IFCC group working on this. Even that might harmonize to within 2 to 3-fold for some assays. And we all know that if it's not within 10, 15, 20%, it's not really worth going. And that's part of that harmonization is using a fudge equation. And I think it's extremely dangerous to use any type of equations to try to align one assay with another. And we're going to see more of this with troponin T now that Roche doesn't have a IP anymore on their troponin T assay. I bet within the next 5 years, we see several high sensitive troponin T assays that are not Roche, that use different antibodies, that use different calibrators, and we're going to see differences in troponin T results for patient care. And there's already a separate high sensitive troponin T assay in China by the ET healthcare people, which gives slightly different numbers. You can look on that one figure I showed in our universal sample bank, 99th percentile. The 99th percentiles vary in sex specific between these 2 different troponin T assays. So it would be wonderful if everyone reinvented their assays, but it's not realistic.
And I'm not waiting for a unicorn.
Okay, well, moving on. A comment here, actually, I think this is really one for Louise, saying the questioner says, I'm a big supporter of point of care, and clearly point of care is faster. But what proportion of patients will only have a point of care test that will be recorded between 20 to 30 minutes? So, I mean, basically, I could say to you, as Louise, as an ED physician, how many of these people are only going to have a troponin, and is that the only thing you're going to be interested in?
I think this is a fascinating question, Paul, because as an ED physician, we've been told for years, nothing you can get at point of care is as good as the lab. You can ignore them all. You don't need anything there. I'd argue nowadays, the vast majority of things that I need in the ED for probably 90% of the patients that I'm seeing, I can get in point of care. I'm not doing your fancy rheumatological tests. I'm not doing a whole lot of other things. I want your basic, hemoglobin, measure of renal function, even LFTs I can get on some near patient / point of care devices at the moment. So we are on the cusp, I think, of a significant change. Now, point of care, I'd argue, in the next 5 to 10 years is going to revolutionise ED management. It is not going to change ICU, hospital management. They can wait 2 hours, 3 hours, half a day. But where it's going to make a difference is going to be, like Christian said, in the pre-hospital, in our primary care physicians, our ambulance services, potentially for diverting patients to the right places to receive care, and also in the ED where time is important. But we've got to look beyond just highly sensitive troponin assays. But up until now, highly sensitive troponin assays have been in a point of care device, have been a big hurdling block for, as I said, a very large, if not the largest proportion of patients coming to, adult EDs.
I mean, can I put it to you, Louise, that if you have somebody who's a young male come in, you wouldn't probably want to do anything else other than the troponin if they had chest pain?
Oh, look, absolutely. And I think in the days of COVID, troponin was all we wanted to rule out COVID myocarditis in the huge numbers of people that we saw who came with chest pain and COVID. Completely agree. So there are groups of it, but I do acknowledge that in the general element, what we're wanting to see is some sort of measure of, particularly if it's elevated, renal function, to identify whether or not there's concurrent renal disease. But also hemoglobin's an important thing to factor in when we're talking about chest pain, for example, with some of our patients who are quite elderly with severe anemia that might actually be causing it. But so I agree. There's a large number of people that I don't think need it, but culturally it's going to take a while before we can say, get used to using this and we're not going to give you access to anything else. I think we've got to go through a transition and a learning phase. And I think the first thing is say, well, actually, what do you really need? And I can give you most of that here now. And it's not just for our chest pain patients, it's for all of them.
So as they say, it's not what you want, it's what you need. Fred, you have a point.
Yes, I think it's important from my perspective, for the audience to understand. Let me back up for a second. I cannot speak for European testing procedures in Asia and outside the US because I don't understand the complexities of how they point of care rolls in and out. But in the US, I think it's users should be aware that it's okay if we had an assay like this one I presented today, the VTLI with the high sensitive whole blood. It would be okay for me to incorporate this assay just in the emergency department, just for the rule out protocol, even though the numbers are completely different than the central laboratory. Because if we're talking about 20 to 60% of patients could go home on a 0, 1, 2 hour protocol, they'll never going to make it to the floor. We don't have to worry about it. So we could have a separate set of 99th percentiles and a separate threshold for our algorithm. So I think what I've seen in the US, and it's very sad, that let's say we offer a 45 to 50 minute turnaround time on our central lab point of care high sensitive, not point of care, central lab high sensitivity assay, they will opt to use the inferior iStack contemporary point of care assay just so they can get a result in 10 minutes, even though they'll miss, and they know they'll miss. We show them the data, 10 or 12% of patients would have been positive by a high sensitivity, but will be negative by the single sample because of the insensitivity of a contemporary troponin assay. So I'm looking forward to when a true point of care whole blood assay is approved in the US, And I think ER physicians, emergency medicine providers will be all over this. I wish manufacturers, they would all get their systems through the FDA ASAP, give the labs choices to go down that route.
I have to agree. Sorry, Paul, I'm just going to keep going on from what Fred's saying. You know, Fred's talking about 10 and 20%. We're looking up 40, 50% of patients that need a single value. And out of that 50%, a significant proportion don't need anything else. The pressures on EDs are phenomenal. And that figure that you talked about, Fred, of losing 20% of the nursing staff post-COVID, we are feeling that everywhere around the world, I'd argue. We need to embrace these innovations to make, you know, a dramatic shift in the way that we're delivering care in certain places, because otherwise we you know, the care that we're providing is of inferior quality. And just, yeah, I don't want to see EDs, you know, the standard of care drop so much because we have patients sitting for 12 hours not being seen with chest pain. And yet I do know that in some countries around the world, the wait to see a doctor when you present to an ED is hours and hours and hours, which I think is not excusable.
Yeah,
Okay.
if I could just add to that real quick, Kristen, I hope I didn't cut you off. One of my dear friends is one of our ER, Steve Smith, one of the ER physicians, and he spent it on a shift. He was the triage physician, and there were 55 people waiting to be seen, let alone get in the front door, because they didn't come in by EMS, an emergency service. And he would say, geez, if I had this type of assay and I could triage these, a lot of them are low risk cardiac, but they do have a cardiac feature why they're in there, he could make clinical decisions very rapidly, crowd this waiting room, let alone the ER where there's no beds anyway to see. So this is especially every big city needs this type of tool to be used.
Okay, I think I'm going to move on here. Another question has been asked here about what about health economics to understand how we can implement such a test, and another someone else actually to point out who's going to do it, because the idea that you actually implement this by saying to the nursing staff, your job. This is something which we have discussed locally in my own hospital, and I've always said this is something that can be done by physicians. But I mean, in terms of health economics, I make an interesting comment. In the first ever study that we did, which is now 20 years ago, of course, and using different protocols, we demonstrated that actually hospital stay halved when point of care was put in. Admittedly, this is in the good old days when we kept people in for 2 to 3 days, but I think realization of benefit is slightly more complicated now, but I still expect it to be there. Over to the rest of you for this one.
I think, Paul, we've got a classic burning platform here. We've got pressures on our clinical staff that are increasing. I'd actually love to see, and I've spoken locally about having a hybrid model of our lab scientists / phlebotomists having multiple skills and coming and working alongside me in the ED. You know, and it even went to the stage of talking about if I've got a 0 and 1 hour strategy, it's their responsibility to then go and take the samples in the right serial time points and run them for us as clinicians. We have got our resources, i.e. nursing staff and doctors within the ED are limited. We've got to start thinking beyond the way. But in terms of how do we measure the economics, we do a lot of studies looking at release capacity. The trouble with talking about the actual dollar value that's associated with this is if I get somebody off a bed because I'm more efficient, somebody else is jumping back in on that bed. I know that. That's just how it is. The queue just keeps coming. But we've got to talk about release capacity, and we do need to do these sorts of evaluations and work alongside the health economists. But I think we've got this great opportunity to potentially create new careers and new opportunities, and the administrators will see that depending on the ways that their services are funded. There are some that may not see it as a benefit as an increased load, but if you're working for a fee for service and you can now increase your throughput coming through your department by 10 to 20% because you're actually moving people through, that actually balances out in terms of cost, but it is different depending on the way that you're funded.
I'll make a comment on this. I love this topic. I work at a smaller hospital. I'm a one health system hospital where we actually can talk to our administrators and sometimes even talk to our ER people who will listen. But Paul, the concept, if you think about it, we all know that if you had a dedicated phlebotomy team in your ER that also could do troponins, what a powerful tool that would be. Because I think of that 0-1R ESC preferred, it's not it doesn't say it's better than 0-2R, but they prefer it. My role as an associate editor for clinical chemistry, when you look at the average and median turnaround times for that 1 hour sample, it's closer to 2 hours when they get the sample, not 1. The protocol is written 0-1, but I would ask everyone on this call if they got the numbers to tell me if you do a 0-1 hour protocol without a dedicated phlebotomy team, what is the true median time for that second blood draw? So I think if you can actually work with your administrators, as Louise pointed out, and point out, if we spent money a little on some FTEs, we could probably, the bed savings and costs would be huge. Not only just to quickly admit them, but to be able to send them home. I think it makes a lot of sense.
Yeah, I just want to add that, of course, if you have a team who are responsible for just taking the sample and analyzing them on point of care, it's not rocket science. So health secretaries do that all over Norway, for instance, use point of care, takes the blood samples. It could also be done in the ED. So it's very easy to have this kind of dedicated staff, and it's not very costly if you want to organize it that way.
Okay, I've got a couple of questions here. One from the same person, which I think it's been partly answered. If troponin I is available by point of care, if lab troponin I is available, should point of care be available in the ED? To which I think we say the answer is yes. And for a small DGH hospital, how should the lab evaluate a new troponin I method?
Do you mean in terms of the assay analysis or in terms of the clinical utilization of it? Because I'm not 100% sure.
I think the answer to that is probably both. But
can I comment on this?
Yes, I think there's one for you.
The top of my head. My recommendation would be that you validate the assay in the same way that you validate all your assays, right? With precision and that kind of stuff, stability, and so on. So the analytical validation would be similar to all other assays, the way you do it in your lab. Regarding the clinical validation, and this is my experience, in Norway we have many small hospitals. And when high-sensitive troponin was introduced in 2009 first and then 2013 for troponin I, we surveyed all the 55 hospitals in Norway who was doing acute cardiac care about the cutoffs for troponin, but the cutoff they used for myocardial infarction, and there was a really large diversity. So depending on this hospital or that hospital, the diagnostic was completely different. So based on that, we tried to agree on using one cutoff. So you don't validate your 99th percentile in every small hospital in Norway. We use what the manufacturers recommend, and that might not be perfect, but it's good enough, because the 99th percentile, that's an arbitrary cutoff. We could have said 97.5 or 95 or whatever to diagnose myocardial infarction. And we also know it varies by age, so and we don't use age adjusted cutoffs. So my recommendation, people do disagree with me, would be to use the manufacturer's cutoff, because then at least you are using the same all over the area. I don't know if that was the answer to the question, but well.
Yeah, I mean, I think the answer to that is that the validation that you can do locally is going to be limited, and it's largely going to be, can you use the equipment adequately, and have you got a batch that has reliable QC? So I would take the approach that I would say do it in exactly the same way as if you were validating a point of care blood glucose system. That's quite a good model. All you want to do is test that it actually works. Because I think you can't do large clinical studies, and you certainly can't do 99th percentile studies. Fred?
You know, just in this point of care high sensitive troponin world we're living in, and the studies Louise and I just published, and Louise showed another one from the Swiss or German group. Here's the key that I think people have to be comfortable with is we are never in a perfect world. You know, we define normality, quote unquote, by a 97.5th percentile, knowing that, let's say there's going to be 5% of population will be abnormal, even when even if you're normal. So if you take the cutoffs we're designing for the upper reference limits for point of care, let's say troponin high sensitivity, yes, we are going to have some misclassifications. It happens with every test. The precisions manufacturers might say they're 7%. We find they're 21%. But the point is, studies like, I'm just going to use Louise and our study. That study showed some safety data, which is real. It's not to be denied that, yes, there's going to be, we all know if we do imprecisions, and studies in the literature show those imprecisions look worse than they manufacturers do. But when you do the studies, we had 2,500 patients, and there's a lot of 2,000, 2,500 patients with assays that have imprecision questions at times. The safety data looks excellent on single sample and 0.2, 0.1 hour samples. So I think laboratorians need to step back a little. We could go through this, the same thing with TSH, every assay that's looked under a magnifying glass in our profession. So I think people have to realize we have great tools. I know it's a little away from the question, but it does address that we're not going to be able to perfectly validate and meet sometimes the manufacturer's recommendations because they're often not done in the real world, all right? So the data literature will speak for itself, and I think there has to be some confidence in the literature and see how it pairs up to the package insert. And Kristen, I'll pass it to you.
Yeah, just Paul, you said you should do it the same way as a glucometer, and I agree. But there is one very large difference between a point of care troponin assay and a glucometer, and that difference is that if I have a point of care glucose instrument, I will of course correlate that to my central platform. And I cannot do that for the troponin because I know already now they are not similar. And that is a challenge. But I think what you need to do is I would actually correlate it to the central platform, and I would see a little bit about how large differences or how many, how are patients classified by the two assays. And then I will look into the literature and see if this concordance in classification that I have in my hospital, is that similar to what is published? And if it's similar to that's published, then it's as good as it gets. And of course, if you have neighboring hospital has the same point of care assay, you can have some correlation with that, of course. But you cannot do like ordinary correlation you would do with glucose.
Paul, I've got a different kind of comment to that, and I have great respect for my laboratorians.
It'll have to be a quick one because I think we're just about running out of time.
No worries. You're in a precision world. I'm in a grey world. It's not all about troponin. Put this back into clinical context. I'm going to miss my unstable anginas. It's not all about troponin. You provide me a piece of evidence, and that's it. But I'm the one that's got to synthesize it into what I need to do. I'll pass it back to you, Paul.
Okay, well, according to my reckoning, we've got about a minute to go. So I'm going to do my wrapping up statement. So thank you, everybody, for attending the webinar. Thank you, Fred, Kristen, and Louise, for the excellent talks. There are some unanswered questions, but we'll try and get some information back to you. But please have a look at the IFCC paper on point of care testing, where I think you'll find a lot of the questions which are being answered, which are being put, are actually answered there. There's a certificate participation at the end of the webinar after a few questions. At the end of the questions, please click Show Me My Scores at the end of the page and get your certificate. The IFC's webinar is actually going to be available through the cardiovascular module courses. So you get a chance to see us all again. So if you're really, you can't sleep one night. And these courses are based on the concept of adaptive learning, so they can help you assess your knowledge in this important area of R&D and maintain competency. So register on the site and you'll find the link for the resources for the webinar, and it's free. Finally, on-demand content of this webinar will be available shortly, and we'll get an email about it. And remember, there are lots of other exciting IFCC webinars coming your way, including some more from us. So I think at that point, I should bid you all farewell.
Thank you, Paul.
Thank you, Paul.
Thank you, and thank you for everybody watching. Thank you.